Hello everybody, my name is Dr Liana Roodt. I am the CEO and the founder of Project Flamingo, and it is my honor and privilege to chat to you today about breast cancer. I hope today's conversation will be insightful, and I hope that during this conversation we can move well beyond the pink ribbon, well beyond just being breast aware, but actually feel empowered and educated around the disease, not just for ourselves, but for our sisters, our mothers, our aunts, women around us that has to face this diagnosis, and see how we can help them. So unfortunately, as I think you are all very well aware, the current statistics from the World Health Organization is quite frightening. 1 in 8 women would face a breast cancer diagnosis in their lifetime. So although this is terrifying statistics, the more we know and the better we educate ourselves, the better the outcomes. Early detection really does save lives, and fortunately, because breast cancer is so prevalent, it is also one of the most researched cancers, and the way in which we treat and manage breast cancer has come leaps and bounds. And a lot of women facing this diagnosis will have an excellent prognosis. Very important is that you be your own breast friend. Knowing yourself, knowing your body, knowing your breast is absolute key to early detection. Nothing beats your own self-examination and self-inspection of your breasts. A lot of people feel incredibly intimidated by this self-examination, self-check. So we're going to quickly talk through it. It really is not that hard. And once you get into a rhythm and a routine to do this, this really can actually save your life. So just a recap on the things that we need to pay attention to. Everybody knows about a breast lump as a warning sign of breast cancer, but it is actually more than that. So when we look in the mirror, when we look at ourselves, yes, obviously if you see a visible lump, that is a red flag. But if you see an annual increase in the size of one breast quite significantly than the other one, remember, no two breasts look the same. None of us have breasts that are exactly the same size, but if you see one breast that is suddenly increasing in size, that may prompt you to actually see a healthcare provider. If you see any dimpling of the skin of the breast, we call it orange peel skin, that is something to pay attention to. A change in the skin around the nipple or a new nipple discharge, especially if you're not breastfeeding, definitely something to get checked out. Feeling a lump in your armpit or the axilla where there's glands, and if you get a dimpling or a traction of the nipple, that is another thing to pay attention to. So how do we do a breast self-examination? When do we do a breast self-examination? Most importantly, if you are still getting your period, pick about 4 or 5 days after your period ended. The breasts are then least sensitive and the least nodular, so do it then. And if you're already postmenopausal, just pick a day in the calendar, stick to the routine, and do it at the same time every month. In order to explain this a little bit better and to make it fun, I've got a little video for you.
Hi, I'm Dr. Rutherford Gray, and it's come to my attention that many women aren't checking regularly for breast cancer. I'd love to discuss how we can change that. But since studies have shown that women are more likely to watch a video if it features a hot guy, I'm not going to. He is.
Hey, I'm Anthony, and I'm here to talk to you about Rethink Breast Cancer's Your Man Reminder. It's an app that gives you regular reminders to check your breasts from a hot guy of your choice.
Hey there. How you doing? Hey, baby.
It also shows you how to check yourself. Hello. With a little something we like to call TLC. The T stands for touch. Start by touching your breast in any way that feels comfortable for you. Try to be familiar with them and the way that they feel. You know, you can do this anywhere, like on your bed, in the mirror, or even in the shower. Now the L in TLC stands for look. And for this one, you're gonna need to use your eyes. Be on the lookout for anything unusual, and if you want to, have a friend check you out. And finally, the C in TLC stands for check. If you notice anything out of the ordinary, even if you're not sure, check with your doctor. Isn't that right, doctor?
That's right, Anthony. You see, TLC is a great way to help detect breast cancer early. Download Rethink Breast Cancer's Your Man Reminder app today. Now available for free in the App Store.
Okay, so no excuses, girls. We can all do our self-examinations. So before we jump into more detail around breast cancer, I think it's very important that there's certain hot topics that people always want to discuss and they have questions about. So the first one is our national screening policy. So in South Africa, we actually don't have a formal national screening policy. We have a what we call is a symptom-based screening protocol. So the National Breast Cancer Policy was written and released in 2017, and mainly due to limited resources, uneven access, and very importantly also evolving global evidence, we have decided that we will not have a population-based screening program. What that means is that there is no specific age in which women are required to start a screening program. However, if you have access to private healthcare, many of the medical aids will encourage you to start going for your mammograms as early as the age of 40. When we look at the international guidelines, the USA still uses 40 as an age to start with regular breast screening with mammogram and ultrasound, while the UK and Canada has adopted later age groups to start the screening. So between the ages of 50 and 70, and only every 3 years, not annually. And this is being refined all over the world. And that is mainly why South Africa don't have a formal breast cancer population screening policy. What is very important, and this is where breast cancer screening is evolving towards all over the world, is to actually do a risk stratified screening. So in other words, to assess every patient's individual risk, and from there build an appropriate screening program for them. We live in the age of individualized medicine, and this starts talking towards it. So there are various online calculators that one can use. If you go to a breast clinician or a gynecologist, they may have access to some of these calculators, and there's certain factors that we look at, and at the end of this, putting everything together, we can project an estimated lifetime risk and use that to guide a specific patient screening. So things that we look at is genetics. Very important that only 5 to 10% of all breast cancers actually has an identified genetic mutation. So the BRCA1 and BRCA2 genes being the most commonly known genes, but there are several other genes that can also contribute to the development of breast cancer. As genetics evolve and we may discover more genetic mutations, we still look quite strongly at family history. So we look not only at breast cancer family history, but all cancers, because there are some overlap. First degree relatives and the number of patients affected in a family obviously contributes to the risk here. Very interesting is a patient's estrogen window, and what we mean by that is when she started getting a period, so her menarche, and when she goes into menopause. So that is your body's natural exposure to your own estrogen. And there is some evidence to suggest that the longer this window is, the higher the risk for the development of breast cancer. Age at first live birth, so women having children and having children earlier on in life seems to have slight protection against breast cancer. Breastfeeding seems to offer some protection against breastfeeding. And then X, the use of exogenous hormones. So that is exposure to hormones that comes from outside of your body. So this is quite contentious because for a long time, hormone replacement therapy was dubbed evil and a major cause of breast cancer, which has now been completely debunked. That is no longer true, and I will talk into more detail about how we can still safely use hormone replacement therapy. It is, however, important to look at the overall hormone exposure of a woman. So very, very long exposure to oral contraceptive use, followed by, say for instance, in vitro fertility treatment, followed by long periods of hormone replacement therapy. We have quite a bit of hormonal manipulation in our food. All of that can culminate into an increased risk. So that is also where lifestyle comes in. Diet, exercise, alcohol, sleep, and stress all plays a major role. When we look at diet, it's usually the usual culprits: our very refined and processed foods, sugars, not great. Exercise, always good for you. Alcohol must be limited. Sleep must be good, and stress managed. So then everybody wants to know, okay, what can I do to image my breast? So our imaging toolbox for breast basically consists of mammograms and ultrasounds. That is the most common imaging modalities that we use. And an MRI is the gold standard in terms of sensitivity, but it is reserved for high-risk cases or patients with extremely dense breast tissue. So why do we use a mammogram and an ultrasound, or when do we use what? So in general, an ultrasound is good to use in younger women with denser breasts, whereas a mammogram is more reserved for older women and patients with less dense breasts. In ideal circumstances, we would like to combine them. I always explain it to patients like you must think of a mammogram as taking a panoramic picture. So you can see there's a hill, there's a tree, and then the ultrasound is the zoom function of your camera. So now you can zoom in certain areas and get more detail of the breast. So that's basically what's in our imaging toolbox. A lot of patients are very concerned about possible radiation exposure through mammograms. It is important to understand that this exposure is absolutely minimal. And if you only go for a mammogram every 1 to 2 years, your exposure risk is really low. And the benefit of doing the imaging and detecting cancer early far outweighs the minor radiation exposure from a mammogram. MRI and ultrasound obviously has no radiation exposure. So the hot topic that I briefly touched on previously is the concept of hormone replacement therapy and breast cancer risk. So for me, really, really important that women understand that this myth has now largely been debunked, and that internationally we don't associate hormone replacement therapy in the average patient as a major contributor to breast cancer risk. Okay, where there is risk, the risk is mainly with combined estrogen and progesterone tablets. Estrogen only users generally has a low risk, but that is something that has to be discussed with your doctors, because if you still have your uterus, you have to use progesterone. You can't use unopposed estrogen. Again, we're back to individualized medicine and really understanding your specific risk. HRT should be assessed carefully in patients with known gene mutations with very strong family history. But the main message is that it really should be individualized. HRT remains the most effective therapy for menopause symptoms that we know can be very debilitating. It also is really helpful in terms of bone health, cardiac health, and there is proven benefit for women to use HRT. Okay. Risk really depends on what hormones you use, how long you use it, what the doses that you use, and what your personal and family risk is. So if you are an average low-risk patient, a low-dose hormone replacement therapy for 5 to 10 years makes absolute sense with very little risk. So remember, in terms of hormone replacement therapy, policies and evidence evolve, context is incredibly important. If we give patients early access to HRT, we educate them around them, we empower them to make a choice, we really can improve women's health and women's quality of life. Okay, so breast cancer. So many opinions. There's so much out there. People get terrified when they start getting information, and we also live in an age of information overload, where we often wonder what information can we trust and what can't we trust. So we're going to try in a very simple way navigate some of the most important things about breast cancer to empower you. So when you discover a breast lump or any of the other red flag symptoms that we have discussed, it is so important that you go for what we call the gold standard triple assessment. So none of these should ever be done in isolation. You need a clinical assessment where somebody can do your history, do a proper risk stratification and a clinical examination for you. You need imaging, which is going to be bare basics, an ultrasound and a mammogram and a breast MRI for select patients. And then you need a tissue diagnosis. Somebody has to look under the microscope, and ideally there should be a core needle biopsy where we can get histology, so that is actual tissue, not just cells, for a pathologist to make an assessment. Not only to diagnose the cancer, but to also understand the personality of the breast cancer. That is a major evolution in the understanding of breast cancer, is that breast cancer is not just one disease. It is actually, it's got one name, it shares a surname, but multiple molecular or biological personalities. And if we understand that, we can individualize treatment. So the breast cancer journey is a long journey. And, I often tell patients this is going to take a year out of your life. And we need to, and I can talk you just broadly through the various phases of the treatment that a patient goes through. So first of all, we need to name the cancer. We need to understand the specific type of breast cancer. Then we need to do something that we call staging investigations to make sure the cancer has not spread. Very important that we never treat breast cancer in isolation alone anymore. It should always be treated within the setting of a multidisciplinary tumor board, where various specialties come together to discuss the patient, the individual risk, and how this individual treatment plan should look. Then we enter the treatment phase, which is usually a treatment basket compiled out of many different things. And then survivorship, which is a phase and a challenge in itself. So the naming of the cancer, why is that so important? So when we just look at the types of cancer, so you get pre-cancer, which we call in situ cancers, and then you've got invasive or infiltrating carcinoma, which is an actual breast cancer. There are many, many histological names. That just means it is the type of tissue where the cancer originated from. So many of them, but the two most common ones being invasive lobular and invasive ductal carcinoma. Okay, that's a name, great. But what we're really interested in now is the personality of the cancer. So this gets quite technical, but this has shifted the way that we understand breast cancer and how we treat breast cancer. And that is looking at certain biological markers and receptors that a cancer can express that we can then target in our treatment. So luminal A cancers being exceptionally hormone sensitive, with quite a low cell division rate, so I call it the lazy cancers. The luminal B cancers that can be either, that's sort of in the middle, they can either be fast dividing or not so fast dividing. They are hormone sensitive, but they can also express an additional growth factor that we call HER2. Then you have your purely HER2 positive breast cancers that only runs on this growth factor, and then basal-like or triple negative breast cancer that doesn't express any of these factors. So like I said, it's like a family. The boertjies from Benoni is not the boertjies from Brakpan. Different situations. So every breast cancer has a different face, it has a different personality, and we need to treat it accordingly. So how this impacts our treatment is not just the type of treatment, but is actually the timing of the treatment as well, and the combination of things that we use. So for some cancers with a certain personality, like a triple negative breast cancer, it's really important to start with systemic therapy. So to start with chemotherapy, now also immunotherapy or targeted biologicals, but we need to start systemically and then do surgery. With our luminal A cancers or our very hormone sensitive cancers, we would often start with surgery first and then go from there to other treatments. So very important that whenever you speak to a breast cancer patient, or heaven forbid you yourself become a breast cancer patient, to never compare your journey to someone else's, because it is supposed to be different, it is supposed to be individualized, and all these factors need to be taken into account. So the treatment basket usually consists out of a variety of these things. It is a type of surgery plus endocrine therapy, which is basically a hormone blocker. In premenopausal women, we have to also suppress the ovaries, chemotherapy, biological treatment, immunotherapy, radiotherapy. All of these get combined in different ways to get an optimal outcome for our patients. I always explain it to my patients like this. This was the other big evolution in understanding of breast cancer, is that breast cancer in your breast does not kill you. Breast cancer, when it happens elsewhere in your body, becomes a real problem. And unfortunately, breast cancer is a bit of a tourist. So think of the breast cancer in the breast as the mothership, and what we want to do is any little tourists that jumped off, we want to prevent them from finding a home elsewhere in the body. So it's the work of surgery and radiation to take out the mothership or head office, and it's the work of the systemic treatment, so be it endocrine therapy, chemotherapy, the biologicals, the immunotherapy, to go mop up and find those little tourist cells and prevent them from actually occurring elsewhere in the body. So complex, but I think that, hopefully explains a little bit more why it's not just one thing that we do, but several things that we do. We have to determine the staging, so that is various scans and blood work that we send patients to make sure that it hasn't spread, and also to help us individualize our treatment. Then we would usually discuss the patient at a multidisciplinary tumor board, and all the specialities are present there: radiology, pathology, genetics, surgery, plastic surgery, gynae, oncology, often a nutritionist, psychologist, and patient navigators, in order to build a treatment program suited to an individual patient. Deciding on treatment, of course, is quite an endeavor and has to be an open dialogue between patients and healthcare professionals, and really looking in detail at that basket of care that we've briefly discussed. Very important for me here is also to, when we talk about surgery, is so there are so many surgical options now. It's not just lumpectomy and mastectomy anymore. We can do so much in terms of oncoplastic breast cancer surgery, symmetralization, that breast cancer surgery really does not have to be a surgery where a patient feels maimed and disfigured, and we really try to do our best to maintain or give back to a patient as much of her femininity as possible. So when very, very important to remember that more surgery does not mean a better outcome. Like everything, surgery also has to be individualized. There are certain patients, especially those with genetic mutations, those that actually have cancer in more than one area of the breast. A mastectomy, so removal of all the breast tissue, is unavoidable. But nowadays we often do it sparing the skin, sparing the nipple, and using either implant reconstruction or the patient's own tissue to reconstruct breasts. In all other cases, if possible and feasible, a lumpectomy, removing the cancer, and you can do it either with a simple mastectomy or with beautiful oncoplastic procedures, is just as safe, if not safer, than a mastectomy. So never think that more surgery means a better outcome. That is no longer the truth. Okay. Oncology, obviously, many layers to that. Chemotherapy, endocrine therapy, radiotherapy, and then very exciting nowadays, our biologicals and our immunotherapy that has really shifted the landscape. Survivorship and follow-up, never to be underestimated. So cancer becomes a lifelong friend for patients that's walked the journey, and actually supporting them through that, and having sort of alleviating the fear of, is this going to come back? Am I going to have to walk this journey again? Really asks for a very comprehensive support network. So making sure the patient has a coping strategy, making sure certain lifestyle changes have been put in place, looking at the patient's sexual health and relationship, dealing with the side effects of the treatment, which is a whole discipline within itself, dealing with what I call the psychology of dread, this thing, I'm a survivor, is it going to come back? So a lot of work and a lot of support that has to go into survivorship. So yes, I guess this is the question that scares everybody. What if I become a patient? And the best advice that I can give is to just stop and breathe. Take a breath. Breast cancer does not have to be a death sentence, and thankfully nowadays it rarely is. There is so much we can do to treat the disease if we just follow one step after the other. It is an elephant and we need to eat it one bite at a time. So calming down, breathing, being in the moment, finding people that you trust, that you can share this journey with, and to actually make this not just a journey where we chase cure, but where we actually embrace healing. So what is, in my opinion, the 5 pillars of healing besides the actual physical healing? Okay, so medicine makes up one part of it. That's the traditional medicine, chemo, endocrine, surgery, all of that. But it's very important that we don't ignore the other pillars. The socio-emotional state of the patient, optimizing the cellular environment through lifestyle changes, supplementation, important for a patient to get their house in order, and the psycho-spiritual aspect of a patient's life that can really improve outcomes and an experience of the healing journey. So when we look at integrative medicine and we look at the principles, what patients do well, and we call this radical remission strategies, is patients that adjusted their diet. There's no specific diet, although there is some emerging evidence for certain types of cancers around the ketogenic diet, and other cancers the Mediterranean diet. But what's very important is patients that become mindful about their eating and that starts to see food as part of their medicine. Patients that take control of their own health and follow their own inner physician, follow and trust their intuition, use certain supplements. There are certain supplements that can certainly help alleviate side effects, make the treatment journey easier, and optimize the cellular environment. Very important to release suppressed emotions, increase positive emotions, embracing social support, deepening of a spiritual connection, and having strong reasons for living. Patients that do this, as counterintuitive as it sounds, have often come back and said that cancer ended up being a gift. And it sounds bizarre, it sounds crazy, none of us want to believe it, but I have had too many patients that have come at the end of their healing journey saying that although hard, this may have been the best thing that's ever happened to me. This is when we embrace the big why, when we embrace our own healing power, when we embrace emotions, our support structure, and really become intentional about the way that we live, the way that we breathe, the way that we are in this world. So this is one of my favorite quotes. Healing represents an expansion of consciousness and a movement in the direction of wholeness or health. We can be healed by our illness, even if we're not cured of it. And on the flip side, we can be cured of our illness and not healed by it. Healing may or may not result in cure. So for me to differentiate these things, yes, of course, we chase cure, we want cure, but if we can combine that with true healing, then we have achieved what we really wanted to. So if you want to support the work that Project Flamingo does, in essence, we're trying to ensure holistic and timely breast cancer treatment for patients in the public healthcare sector that really struggle with extremely long waiting times to get the treatment that they deserve. And this is where we step in. So if you want to look at the work that we do, how we do it, and how you can help, please visit our website. There's a wealth of information on there. There's also quite a bit of patient information, patient support information that anybody can access. And I want to invite you to go and have a look at it. Thank you so much for your time, and thank you for giving us an opportunity to chat to you, to hopefully broaden your horizons, educate you around breast cancer, beyond just a pink ribbon that you put on your lapel or that you wear during October, but to really understand, comprehend what we are talking about, understanding that awareness alone is not enough, education alone is not enough, although that is the first and most important point. We actually need to be able to access treatment. We actually need to be able to provide treatment. And it's so important, more and more so, that treatment really is individualized, that it's offered in a team setting, and that we don't just look at the patient as a mere body, but as a human, as a woman that deserves love and compassion, and for us to really make room for her.